Good morning, everyone. It's Monday, July 7th, 2025, and we're here this morning for another work session. Our discussion item is Longview, the Adolescent Service Expansion. I'm Kristen Stevens, Chair of the Board of County Commissioners. With me are my fellow commissioners, Commissioner John Kafalis and Commissioner Jody Shattuck McNally. Our County Manager with us, Lorinda Volker, and I will turn things over to Amy Martonis, Behavioral Health Services Director. She has other folks with us. Laura Walker is also in the room. So want to say welcome to everyone. You can introduce yourselves as you speak, but Amy will let you start the presentation.
Good morning, Commissioners. Amy Martonis, she, her, serve as the Director of Behavioral Health for Larimer County. Very glad to be with you this morning, and I'm joined by three colleagues with Summit Stone Health Partners. And I'll invite them to introduce themselves and then share a little bit of context about our time together this morning.
Good morning, Commissioners. Thank you so much for having us. My name is Leslie Brooks, and I serve as the Chief Medical Officer for Summit Stone Health Partners and the Executive Director for our services at Longview.
Morning, Commissioners. My name is Brian Ferens. I serve as the Deputy Executive Director for the Acute Care Facility for Summit Stone Health Partners, and I'll share a little bit about some of the operational pieces of the adolescent unit expansion.
And good morning, Commissioners. I'm Cassie D'Amato, and I serve as Summit Stone's Director of Acute Services, and I will be sharing a little bit about our clinical services, the treatment that we'll be providing for adolescents.
So we are all excited to be with you today, and I wanted to share some context as we share about the expansion of services at Longview to include overnight care for adolescents. But I wanted to zoom out just a little bit and offer the context that in 2018 our community made the very forward-thinking decision to tax ourselves 25 cents on $100 so that there would be dedicated funding for behavioral health services and access to increased scope of services across our community. Part of those funds, a major investment of those funds, has been the creation of the acute care facility out at Longview, 2260 West Trilby Road, where crisis behavioral health care is available to all ages through a behavioral health urgent care. And this is a community-wide resource. If you have private insurance, if you have Medicaid, if you are underinsured or uninsured, these services are available to you. So it's a community-wide resource. Services for adolescents have been part of the facility through the urgent care, but we have not had overnight care for adolescents since the facility opened in December 2023. So in response to community need and recognizing this as a priority to expand adolescent services, we are delighted to be here with you to share more of the services that are coming. And today actually marks day one of the construction and facility changes that are underway to support these services. To align with increased licensure regulations for caring for adolescents overnight, there were some structural changes that needed to happen on the unit where these services will be provided. And that construction started today and is anticipated to last for about 4 weeks. We're looking forward to hosting a community event September 15th. More information will be coming out about that soon. And we will anticipate a launch end of September, beginning of October, of opening these services. So those steps are underway. With that context in mind, I'm happy to turn it over to our Summit Stone partners. They are our contracted vendor for providing the clinical services at Longview and have been tremendous partners in designing, thinking about, and being responsive to the youth needs in our community and the services that are being designed to meet that need. With that said, I'll turn it over to my colleagues.
Thanks very much, Amy. If you one more back. So, thanks so much again for having us, Commissioners, and for inviting us to talk about how we will serve adolescents in overnight care at Longview. And I won't spend a whole lot of time on this, but this is Summit Stone's vision mission to make Northern Colorado the healthiest community in the nation. And our mission is to serve our communities by fostering trust, empowering recovery, and inspiring hope. Our values are, and it's relevant to how we are going to care for everyone who comes to Longview, but especially as we talk about bringing adolescents into our care, is come as you are. We start with yes. We are stronger together, and we boldly raise the bar. So in introducing adolescent care and adolescent services, overnight care at Longview, I wanted to cover just briefly what we're already doing at Longview. We have 10 exam rooms for urgent care and bridge clinic services. We have 6 beds in our 23-hour observation. We have 16 beds in a withdrawal management unit. We have 16 beds in a crisis stabilization unit. So all told, we have 32 plus 6, 38 beds for folks at Longview. What is coming, we have 56 beds total at Longview. We have 8 adolescent beds that are coming later this summer, and that will leave us with a 16-bed unit that is vacant that we hope to open in the first quarter of next year. This is the client experience pathway, and I just want to point out here, we have always served adolescents and children in our services, and they typically everyone comes in through urgent care, but we serve them in urgent care where we will assess everyone, and as well as in our observation, in our 23 observation. That is a place where we have always served adolescents in our current services. So expanding these services, we now, and you can go to the next slide, we will open 8 beds for crisis stabilization for adolescents ages 12 to 17. We'll focus on behavioral health crisis generally, from mental illness and substance use. As for adults, we'll also offer pharmacy services and lab services, because that is key to really having a client experience of care that is really robust, and not having to send people back and forth to emergency rooms and hospitals, and being able to keep them in our care as having those medication and laboratory services available. The length of stay for our adolescents is short-term care. This Longview is acute care. It is not what people traditionally think of as residential care for adolescents, which can be months at a time, 28 days, 60 days, 90 days, even longer. Longview is acute care, so that stay is 5 to 7 days on average, could be a little longer if circumstances dictate and approvals are obtained, but that stay is generally 5 to 7 days. This is in addition to what we've already done in urgent care and 23-hour observation. We will open with 5 beds and expand to 8. That unit has 5 bedrooms. 3 of those rooms are double occupancy, 2 of them are single occupancy. So we will initially open with 5 single occupancy rooms and expand to 8 as our experience and practice dictates. We will initially open these beds to youth referred through Larimer County Department of Human Services. The county's Department of Human Services is one of our closest partners in our work with youth, and we thought it made sense to have a bit of a soft opening with our closest partners, and opening those beds initially to referrals from them, and then expanding to community-wide, again, as that experience and practice dictate that we do that. So with that, I'm going to turn it over to Brian.
Can I ask a question?
Of course.
Okay, we'll let Commissioner Shattuck McNally go first.
No, go ahead, Madam Chair, I don't mind you going first.
So my question is, because this is short-term care, acute care, do you imagine that most of the young people that you're going to serve will need further sort of inpatient care, and will have to move into a different kind of facility, or is the idea that they can be stabilized and maybe sent home and maybe have outpatient care? Because I don't know a lot about this work.
Sure. Thank you for the question, Commissioner. I'll also invite Cassie to chime in here. But the answer is a little bit of both. In our adult care, 60% of people we're able to stabilize and safety plan and get folks care in the community, whether that's with Summit Stone or another behavioral health partner in the community. Some get admitted to one of our beds, and others yet need higher level of care. And we will also do that bed finding for placement. And the same will be true of our adolescents. Some will be able to stabilize in our urgent care, and we can get them back into the community. Others will need to put into one of our beds, and others still may need placement at a higher level of care. Cassie, anything you want to add to that?
Yeah, thanks, Dr. Brooks. So, an important element of caring for kiddos is ensuring that we're incorporating their natural supports. So, family members, members of DHS, and so that is such a critical component to the care that we provide currently. But when we have folks stay for a few days with us, we have the ability to engage with the families, very differently. So ultimately, we would love to be able to stabilize and safety plan collectively with the family members and with their natural supports and get them to the least restrictive environment. But as Dr. Brooks said, there are times where we might need to send someone to an inpatient level of care as well if they need that further stabilization and safety standards.
Thank you. Commissioner Shattuck McNally.
Thanks, Madam Chair. So I'm going to build off what you said. Something similar, and then I want to just confirm real quick, though. You said 60% of the folks that are, that you said were stabilized and able to be stabilized and in the facility and sent off with a warm handoff to supportive care after their stabilization. I want to make sure I understood that number.
Correct. Thank you, Commissioner. Currently, through our urgent care, 60% of folks, we admit about 40% of folks to a bed at Longview. So 60% of the folks that we see in our urgent care are able to be stabilized, safety plan, and get back out to the community.
Great, I appreciate that. So my question is, so I'll make sure I heard that number correctly. I have a lot of thoughts running through my head at the moment. So when we talk about initially youth referred through Larimer County Department of Human Services and expand countywide, I understand the process for that and understand the need, and it's important. We know some of these youth, but I'm also wondering, there are folks, youth that are coming in through the stabilization service, the acute care, that might need longer than 23 hours of service that come into the center. Is there going to be, in their Larimer County residents, is there going to be a possibility for those with the highest needs be able to access that longer care, or is it just through the referral program, or a little bit of both? Does that make, am I making my question?
Can you say that again,
So
Commissioner?
when you talked about, when I see that it says initially open to youth referred through Larimer County Department of Health, that sounds like there's someone out in the community that might need a longer term and that they would come. But also we have folks showing up into the acute care stabilization center, kind of the drive up, let's say, that needs probably longer than the 23 hours that we can currently provide, or you can currently provide. So I'm curious, when I say we, I mean I'm wondering if there's any room or availability for those youth that come into the front doors that maybe need longer than 23 hours. Hope I worded that.
Yes.
So I'm trying to be articulate today. I need more coffee.
No, that's okay. I think if I understand your question is, when will youth who are not necessarily referred by the Larimer County Department of Human Services find the ability to be put into one of these beds?
Well, I'm just thinking if there's a referral for someone who didn't show up at the front door with a high need, but they're still Larimer County resident, but need maybe a longer stabilization than 23 hours, is that going to be a possibility, or are we just waiting to only have the referrals?
So initially, we will start with those referrals from the Department of Human Services.
Okay.
To put kiddos in beds. And we thought that would be a great place to start, to do the learning and develop the practice and the muscle memory around the care of this population in a bed. Currently, we have youth who, about 6 to 8% of the folks that we see in urgent care are under 18 years old, and we see them in urgent care. We can place them in 23-hour observation. We also do bed finding for those individuals to get them where they need to go. But I think your question has to do with when will those individuals be able to be placed in a bed at Longview? And I don't have a time frame for you, Commissioner. I think that we need to get some experience under our belt with our current relationship with the Department of Human Services, the county's Department of Human Services, and then figure out when we would be able to open up to the rest of the community.
Okay, thank you.
Does that-
Yep,
did
you
we
answered
get
my
to-
question. Yep, you did, and I apologize. I was trying to ask it in the way I was seeing this as two different populations, so thank you for answering that.
And if I can add, our team would be happy to provide an update at 30 days post-soft launch of status. of how things are going, what the transition plan is, and hopefully be able to offer a community-facing timeline at that juncture once services have been open for a handful of weeks.
Commissioner Gonzalez has a question as well.
Thank you. Thank you all. I have two questions. The first one is, if 60% of the folks who come into urgent care are able to be stabilized and therefore step down into the community transition, presumably within whatever the recommended guidelines are, within a week or less, the other 40% might require inpatient care long-term. Where do those folks go? We have a lack of adequate, especially with high acuity needs, facilities. We're trying to address that, of course. So that's my first question. Where do we refer those folks?
Thank you for the question, Commissioner. And just to clarify, it is 60% of the folks coming into urgent care who we are able to stabilize and get out into the community. 40% of those people we admit to beds at Longview. Does that clarify?
Yes, it does. Nevertheless, there is a need for people to be referred to inpatient care more long-term. Where do we send those folks? No, but thank you.
Sure.
Thanks,
Sure.
Leslie, for clarifying that.
Yeah, so obviously we have a working relationship with UC Health, and we coordinate, inpatient care between our facilities. So the referral to our local, try to keep, if it's kiddos, local in our community as much as possible. And then we do refer to other facilities outside of our community if needed. But that, working with UC Health and the expansion of the beds that they have coming to their inpatient level of care certainly will be helpful whenever we're trying to place someone at a higher level of care.
Thank you. My second question. Can you provide a sample of the kinds of issues that are prompting folks to visit the Longview Acute Care Services Facility, adolescent issues and adult issues? Are they similar? Are they different? What is a sample of the kinds of issues that prompt people to be in an acute care situation?
Thank you, Commissioner. If I could, we've got just a couple more slides to get to, and I think we will come to your question. Would that be okay?
Yes, absolutely, you may.
Thank you.
I believe you can, but you may.
Thank you. Brian, do you want to talk through the operational?
Yeah, so just to provide you all with an overview of sort of some of the moving parts that we need to complete to operationalize and implement this new unit. So there's some licensure needs that we need to complete with the Behavioral Health Administration. We had to get our endorsement for CSU level of care for adolescents, and as we already had our adult endorsement for those services, and so that's been completed. We also need to get licensed as, or needed to get licensed as an acute treatment unit, an ATU, which is another level of care provided for crisis patients, and we had to do that because of some federal IMD rules and laws, which we won't get into today. But by adding the 8 adolescent crisis beds, that leaves our total of 16 crisis beds, and we can't have more than 16 crisis level of care beds in this one facility. So we've got to do, in order to maintain our capacity for adult crisis, we needed to seek ATU licensure so that we can still serve 16 adults on that unit. So we also have to get a residential child care facility license through Colorado Department of Human Services, and that is in progress. We had a site visit a couple weeks ago. Everything's on track. We've got some construction elements that they'll sign off on after those are completed, but everything's on track. And we recently got approved for the waiver for seclusion and emergency medications, which is fantastic for us and for the clients in the community for us to be able to do that. And we are super grateful for the partnership and help that Larimer County provided for us to get that waiver. Marketing communication needs. So, we continue to have a lot of conversations with our partners in this work, and we have certainly been talking with them about the expansion of these beds and this level of care coming to the community. And as Dr. Brooks mentioned, some specific partnerships with Department of Human Services for referrals. And then I know the county is also planning some community-wide marketing and communication so that the community knows that these beds are coming. Recruitment, so we are actively recruiting for the positions to then staff this new unit. And so things are on track there. Again, a mix of our interdisciplinary positions, nurses, physicians, clinicians, safety folks. And then, as Amy mentioned, some facility changes. So in order for us to serve adolescents in a bed next to adults in a bed in the same facility, there's some licensing and some built environment things that need to change with the facility. There needs to be sight sound barriers between adults and adolescents and make those units very distinct and separate. And so the county is working on those construction plans. So.
Commissioner Kafalis.
Thank you. So, given that the soon-to-open adolescent care facilities serving youth 12 to 17 for 5 to 7 days, why do you have to get licensure as a residential child care facility? And is that to be licensed as a QRTP, Quality Residential Treatment Program, or the one that's higher skill level, the psychological PRTF? Thank you.
Yeah.
So why?
Well, that's a great question. I'm not sure I can answer for Colorado Department of Human Services on why we need an RCCF license to provide crisis level of care, but that is a requirement through them. So we are seeking the residential child care facility license, which is the minimum license that we need to provide these services, and not seeking the QRTP or the PRTF licensure, which is a higher level of care and longer term care for adolescents.
Thank you.
And I'll just add, Commissioner, both of those, the QRTP and the PRTF, really were longer levels of care than we believe that we are structured for or that Longview is really built for. To have people in our setting for 60 days, 90 days, 120 days, just logistically and structurally, that we felt like that would be a taller order for us. Further, both of those levels of care require additional staffing. Like when you keep a child in a bed longer than 15 days, you need a teacher. And you need to ensure that educational services are available. And that was something that was also.
If I may quickly,
Of
thank
course.
you. If I may quickly, sorry to interrupt, to follow up, but the residential child care facility is a lower level of care, but yet we still need that licensure even though young people would stay there from 5 to 7 days?
Yes, sir. As we sought education around what type of licensing we needed in engaging with both the Behavioral Health Administration and the Colorado Department of Human Services, we were guided that we needed both. And the reality is that the state has competing oversight for putting children in embedded care that comes from from three places: the Behavioral Health Administration, the Colorado Department of Human Services, and the Colorado Department of Public Health and Environment. There are 3 state agencies that oversee this care, and that's the way we were guided when we sought licensure.
And perhaps I'll have a conversation with Laura Walker just to get further clarification. Thank you.
So I will turn it over to Cassie now to talk through key aspects of treatment.
Wonderful, thank you.
Fantastic. Thanks, Dr. Brooks. So when we talk about crisis stabilization services and what this level of care as a crisis stabilization unit for adolescents provides, it really does open the door for individuals or adolescents in that self-defined behavioral health crisis. We also are able to provide withdrawal management services under the crisis stabilization unit license as well, which is a level of care that, as you all know, has not existed in Larimer County. So to be able to expand this beyond the 23 hours like like you were saying, Commissioner Shattuck McNally, will be fantastic to add withdrawal management beds for our adolescents under this umbrella of crisis stabilization. So other things that are considerations are really looking at medical stability, and we will coordinate with our local emergency departments and hospital partners for that immediate stabilization. So similar to the service that we provide now, if someone is in need of that medical trauma or emergent care, we will coordinate with our emergency department and ensure that individuals are physically safe to be within the facility. The level of care of crisis does offer medication management, so as you all know, child psychiatry is very challenging to find appointments to. So any individual who will be staying with us will be able to be seen by our med providers on a daily basis and as needed. So for someone to start medications, maybe for a kiddo who's never been on medications, to be able to monitor, that is just a really critical component to the care that's provided there as well. And then, as Dr. Brooks referenced, we are working in close collaboration with Larimer County Department of Human Services. So we'll start with, referrals from DHS, and we've been working with them over this past year, really, in defining what considerations that they identify and the kiddos that they already identify that could benefit from this service. And so with the treatment that's provided, we, like in all of the other care at Longview, have an interdisciplinary team working collaboratively, providing care. So we have a staffing makeup of, clinicians, therapists, providers. We'll be hiring a child psychiatrist, a child psychologist. We have hired a child and adolescent specific occupational therapist who has experience in the inpatient setting, which has been critical in our program development. And then we provide peer specialists, our behavioral health techs, care coordinators, and then nurses. So a really comprehensive team of providers that will be accessible and designed within programming while adolescents are on our unit. So some of the modalities, the clinical modalities that we'll be utilizing are just listed here: motivational interviewing, the adolescent dialectical behavior therapy, or ADBT, the trust-based relational intervention. That is a training that Thad Paul actually introduced us to and is offering to provide us through DHS, so we can have a similar approach to providing that just philosophy of care and philosophy of working with adolescents, similar to what our caseworkers do in Larimer County. We have biofeedback and neurofeedback that will offer kind of an alternative intervention that our outpatient teams use at Summit Stone. So we're aligning some of the care that's provided within our continuum of care. We have the collaborative and proactive solutions. So that's an occupational therapy intervention, trauma systems therapy, a nurtured heart approach, AccuWellness, CBT or cognitive behavioral therapy, and a variety of other treatment modalities. But so those are some of the trainings that we have already slated for staff who we've identified to work on the unit. The staff that will be hired all have, we're recruiting individuals who have experience working with kids and adolescents and have a unique, interest in different modalities and really being creative and innovative with some of the treatment that will be provided within the programming there. I spoke to this a little bit earlier, but the importance of having sound care coordination and linkage to the family and caregivers. So really working with our providers and clinicians and treatment providers to provide comprehensive care planning, recovery planning, discharge planning with our family members, because some of the most important work that we can do is introduce someone to therapeutic intervention or medications, but then strengthen the linkage that someone might need for ongoing care after they're within our care. So ensuring that we have good connections to providers outside of our care.
Commissioner, do you have a question?
Yeah, if I might, I'm sorry to interrupt you, Cassie, you're on a roll there, but this was a conversation I've been thinking about as I've had out in the community for years, and then also was kind of brought up this morning at their community meeting at the Behavioral Health Services had the facilitate conversation. It seems with engaging family and caregivers and kind of that, I see visit station schedule and recovery planning, will there be any kind of help to support caregivers or family caregivers, or just caregivers in general, how to de-escalate, or any skills or any kind of support for them to kind of be prepared with more skills when their loved ones or who they're caring for come home. You know, even something that I've heard from other folks tell me, like dimming the lights, or not avoiding these scents, or do these scents, or just some general information, or a data sheet, or I'm just wondering about that, because it seems like our caregivers from what I call the kind of the twos to the grays, you know, or the cradle to the grays, need maybe some support with how to reduce their stress, but also be able to understand maybe what's happening is not personal. It's just how their person they're caring for is processing. I'm just curious about that.
Yeah, great question. Thanks, Commissioner. And, you know, part of individual treatment is also psychoeducation for any of the caregivers that are provided. So family members, it might be a caseworker. So that's why whenever I talked about all the different modalities that we utilize, there might be a different modality that works differently for each kiddo. And so we really try to tailor individualized treatment planning and care planning and the interventions utilized. So whether it's with an OT or a medical provider or a therapist or one of our techs, really acknowledge and recognize a certain coping skill might work really well for one kiddo. And for us to be able to provide psychoeducation on how to intervene with a child in a home is really critical. So for us to be able to develop and design that safety plan in conjunction with not only the child, but the caregiver or an identified support. Sometimes that maybe isn't the parents, maybe it's someone else in a child's life. So really being able to wrap around that psychoeducation and link back to what maybe worked on the unit, what didn't work on the unit, what identified interventions that the child responded to, and then not only provide that psychoeducation for the caregivers, but also the ongoing treatment team. So there's something that we might be able to really glean from a 7-day stay that an outpatient provider might not see at all. So the opportunity for intervention when we have folks stay with us is really 24/7, which is very different than whenever you're sitting in an outpatient appointment for an hour at a time. So I think that there's opportunity not only for families, caregivers, but then also other treatment providers. So we provide that comprehensive care.
Thank you, Cassie, for those insights and great points. I appreciate it.
Thank you.
And before we move on, I just want to make sure, Commissioner, that you got your question answered around sort of what types of crises our adolescents present with. And they look very similar, not dissimilar to our adults. They come in dysregulated for a whole host of reasons. They come in with substance using needs. They come in with intoxication. They come in with sometimes aggression, sometimes a fear or desire to hurt themselves or others. Cassie, do you want to add to that?
Sure. I think, we have seen quite a bit of substance use with adolescents. So I think that that's something that we've heard from referring partners, that they are just excited to not only have the ability for someone to maybe start medications in our urgent care now, but for us to be able to actually serve in withdrawal as well. So I think that's something that we've certainly seen more of now that we have the services available.
Go ahead, Commissioner. No, that we only have about 20 minutes left to
Yeah.
get.
And we can say this to the end, but I'm curious, based on what you just shared, are we seeing, there are certain marginalized groups, youth, that are perhaps at greater risk, such as the LGBTQ plus community? Interested to know, or I think we all would be, are we seeing some of those young people because of all the reasons?
I don't know that I have that data for you at the ready, but I believe the answer is yes, anecdotally, yes. And I believe that we have a team who are obviously still learning. We all are still learning about how to robustly meet the needs of this population. But we have dedicated ourselves to making sure that we provide equitable services to the folks who come to Longview. The way that we do bed placement takes into account someone's gender identity, their sexual orientation, their needs around privacy and things like that. So those things are taken into consideration as we look for placing folks in a bed and delivering care to them.
What about youth that are have intellectual and developmental disabilities?
Thank you for that, Commissioner. That is one of the reasons that we currently have PRN psychology team members, and why we will also employ a psychologist, because that neuropsychiatric evaluation is really important to teasing out what is it that is happening within this crisis, and being able to do the testing that is required sometimes that doesn't always get done in a school setting and doesn't always get done by the time folks are adults to identify those needs. And we have done that, and we'll continue to do that as needed, to refine our diagnoses, to make sure that we understand really what it is that we're treating and deploy the appropriate resources. Shall we?
Thank you. Yep.
We have
Move
2
on.
more slides. Do you want to talk through the curriculum?
So this is a small slide up on the screen, but on the print off, you may be able to see a little bit closer. But essentially, this is an example of what our daily programming looks like, and I think reflects the critical need for structure in an environment in which we're serving our children. So it does reflect some of the treatment modalities that I referenced before, but to your point, Commissioner Shattuck-McNally, really building in lots of self-care and consultation and practical learning. So giving an opportunity in a setting in which we stay overnight, you have an opportunity to teach lots of hygiene, timeliness, personal kind of planning and management around if they are in school, how to manage time. So things in addition to therapeutic interventions that I listed as well. So you'll see various sections of our day represented in each of those ideas as well. But really kind of identifying that we have, breakfast built in, that we have self-care. We start the morning with movement, really kind of slow movement to get bodies moving. And we have an OT team that can design this care. We have different mindfulness and AccuWellness, so really focusing energy and time in the morning before we dive into really cognitive driven groups and individual sessions in the afternoon. So we have lots of personal planning, so individualized care plans, treatment plans, safety plans, discharge plans, those things that we were talking about. And we, like I said, we have OT that will be incorporated into every day. We have clinical groups, some of the evidence-based practices that I referenced earlier. We have organized milieu time with the courtyard that Brian was talking about that's being reconstructed. And then different coping skills, different creative expressive groups, lots of, again, another movement group, and then dinner and milieu time, additional planning, and kind of a wrap-up for a reflection of all the goals that happen, and then just some self-reflection and wind down and journaling for everything that they may have learned that day and anyone that they may have interfaced with. Like I said before, we have a multidisciplinary team that they may interface with 5 different disciplines in a day and glean something different from the interventions that the different disciplines provide. So it really is comprehensive when you think about treatment that's provided within a 24-hour time frame and all the different modalities that could be introduced as an introduction. So like I said, the linkage to ongoing care, this is a way for us to introduce different concepts and different methodologies into care and then link them to ongoing care.
Commissioner Shattuck-McNally?
This is probably a complex question, so if we need to, in the interest of time, need to talk about this offline,
Sure.
I'm more than happy. But I looked at this, and the first thought that came to my mind was the dramatic reduction in screen time. And a lot of these youth, me included, I have 2 of these. And I have the computer open. I am curious, that would be quite the dramatic change for some of these folks. I'm assuming they won't have their personal devices, and if that's a complex question to be answered later, but I'm assuming that is part of the process, is maybe getting youth and any of us to disconnect to connect. I'm just curious about that.
Yeah, it's a great question and a great consideration. Much like the schools, I think, manage screen time and use of personal devices. We do have to provide them access to a personal device, but also why we intentionally develop curriculum that's structured and in a variety of different capacities. So I think that there's so much that we can do with our adolescents in a dynamic and very hands-on approach to the activities that we provide. And not every group on here will be a full hour. Some will be 15 minutes, some will be 30 minutes. We'll adjust as needed, depending on how a kiddo presents. If they're able to engage for as long as we have scheduled, that's great. If not, we'll tailor a plan and change activities. But the idea is really to remove that stimuli, and sometimes it could be a trigger. So as we know, social media drives so much of our lives and our youth's lives. So really being able to monitor that and learn and teach some skills around healthy use of electronics it's a reality of our world, and we have to incorporate that monitoring, but also the realistic use of personal devices, I think, is important as well.
Thank you so much. I appreciate that.
So we have just 2 more slides to get through, and then we can answer
Perfect.
more
Sounds
questions. So just wrapping up our treatment and curriculum, Commissioner Shattuck McNally, I think you asked about skills around de-escalation. All of our staff receive training in de-escalation and boundaries and crisis prevention to create and maintain a safe environment for our staff and our clients. Those things are critical to onboarding for anyone at Longview, and will also be true for our adolescent unit. As a last resort, we will, and as dictated by orders placed by our medical staff, we will utilize seclusion, emergency medication, and physical restraint to address safety concerns. So those things that was part and parcel of the waiver that we sought, to be able to do those things, because they are allowed under our BHA endorsements and licenses, but not allowed under an RCCF license. So we needed to harmonize these 2 state agencies who oversee this care. So that waiver has been sought and obtained, and we'll use those tools as needed and as a last resort. So we can go. As with adults, the care of adolescents with mental illness and substance use can come with people arriving in a state of crisis. I mean, that's what this is. This is acute care. That is the work that we do. People arrive in various states of crisis and dysregulation and stress, and we are trained to meet folks where they are. But when this happens, when dysregulated behavior and aggressive behavior happens, there are some consequences to that. Property damage can happen. Physical interactions with staff can happen. The need for emergency and involuntary management to ensure safety of clients and staff can be really paramount in those situations. And so those things will happen. Summit Stone and the Department of Behavioral Services remain committed to ongoing dialogue and feedback on the process and progress in this scope of care. So it is possible that as happens now, that complaints will arise in this care. People may outreach to you individually. There are formal avenues for complaints to be received, both at Summit Stone. Summit Stone has a client advocate, and the organizations which the state entities who regulate us also have avenues for complaints and concerns. The BHA, the regional accountable entity, who are our payers, the Colorado Department of Human Services, the Colorado Department of Public Health and Environment, all have formal avenues to lodge complaints. So we just wanted to make you all aware of those avenues that can happen for complaints. And should you have community members who outreach to you, please feel free to call Amy or myself. if you have questions about any of the care that arises at Longview. Do you want to talk about this one?
Thank you. As mentioned earlier, we're looking forward to sharing some wider community announcements now that construction is underway and timelines for that work get solidified. We're anticipating a community opening event on September 15th, and more details will be shared about that in the coming days, but we're looking forward to sharing the unit with folks and inviting folks to Longview to see the unit in the space where this care will be provided. Thank you for your time this morning, and we invite more conversations and discussion.
Thank you, Commissioner Shattuck McNally.
Quick question. Thank you, Madam Chair. Thank you all for being here today. Super excited about this. Such an important need. We know it's been a need for as long as I can remember, 15, 20 years. When we talked about the opening, we talked about also taking that chance to celebrate the first year of Longview, and we're kind of getting out from that, but we're still getting closer maybe to the 2-year. There'll be a chance to celebrate Longview's first year of success and some of those things as well at the same time as this opening and this community engagement. I'm curious about that.
Absolutely, yes. Thank you.
Thank you. Commissioner Cavallis, questions?
First of all, thank you very much. Appreciate all the amazing and excellent work. It's been quite a process. I do have a question, and given that the first phase of the implementation of the Colorado System of Care began July 1st, which includes a workforce training center in the fall, how are what Cassie and others have described in terms of treatment modalities and step-down processes? I mean, the goal of a lot of that I've been involved in is to implement even young people with high acuity needs to be able to care for their needs in the community with things like high fidelity wraparound services and all of that. So I'm curious how what you all described aligns with that. I assume it does in terms of best practices and what the state requires of us.
Yeah, and I'll let Cassie chime in here as well. But we think we are well poised as a community, as a robust community mental health center, to meet the needs of high fidelity and closely wrapped services for adults and youth. Between our care coordination and peers and multidisciplinary team at Longview, as well as our team in the outpatient setting, where we also have case management and peers and therapists and prescribers, as well as Summit Stone also has a residential care facility for adults, not for youth, but for co-occurring disorders, for substance use and mental illness at Garcia House. We believe that we are well poised to usher someone along a robust continuum of care from the highest acuity to care in the community.
And thank you for the question. And as I said, some of the treatment modalities that we designed and are training to are modalities that are adopted in our outpatient continuum or in partnership, with DHS. We've also partnered with Imagine Zero in providing some specific training for youth and adolescents and the LGBTQ population. So I think that it really is a community effort in acknowledging the importance of incorporating, again, what we do in this facility with the continuum of care that exists, outside of a crisis stabilization unit is important, and that's where we are able to make the biggest impact, is when we absolutely make a connection where we're educated about the services that are available in the community, whether it's within the Summit Stone continuum or not. That's an important part of our discharge planning process, and really we say that discharge planning starts on the day of admission, because it's part of the intervention we provide from the beginning all the way through the day that they leave.
Thank you. Well, I'll maybe ask one last question, and then we can adjourn for the day. So in looking, and this is probably for Cassie, so in looking at the curriculum, there's very interesting to me, because there again, I don't have as much experience maybe as even my colleagues do in this world. very structured. Is that pretty typical is that more for adolescents, or or adults kind of have sort of this whole curriculum that they go through every day?
Thanks for the question, Commissioner. And absolutely, I think it's important to be able to build a template and structure and then tailor the care to individualize the actual treatment plan for each person that comes through. So like I said before, we may have, the best laid plans for every one of these groups to happen, but maybe there's an adolescent that can't sit through all of the groups, but we then have an individual session with a BHT or with a therapist while the OT is providing a group session there. So while this is really highly structured by design, the care that's delivered is absolutely individualized to what is going to best serve and what's going to best meet the need of whoever it might be, whether it's an adult or an adolescent, because we want the care that's provided to have meaning and to be intentional in why someone might be coming for care, because not every person's anxiety looks the same. So really to be able to design an effective treatment plan with the individual and with adolescents with the caregivers that are then deploying the interventions at home. We want it to be practical as much as possible and something that can be long-lived and can be linked to the care that they're receiving in an outpatient setting. So whether that's medication management or a therapeutic intervention.
Thank you for explaining that, because it seemed like a lot of, and you kind of had answered my second question, a lot of things felt like sort of group activities more than sort of
Yeah.
individualized.
Yeah.
But that apparently can change if there's needs in different spaces. This was just obviously a sample of
Yes.
what the curriculum
Yes.
might look like, so very interesting to me. All right, any other questions before, County Manager.
And forgive me, Madam Chair and group, I have a national call in 3 minutes. I've got to go get on. Thank you.
County Manager Lorinda Volkman.
Briefly, I
Yeah,
just want
please
to
go
wrap
ahead.
up by saying, not having adolescent care was part of the original plan, so this wasn't a lack of planning. You might recall that we did want to get really good at the services Summit Stone provides inside the facility, and so that's why we're slowly expanding these services through Amy's contract management and the work of Summit Stone to address these needs. We know that adolescent care was something that voters said was really important, and it is really complicated, as you heard today. Some of these licensure issues make it a little more difficult to do that. So I appreciate the creativity you all have used to try to make this work in a way that is a good test to validate that we can actually provide these services there. And I know that there will be bumps in the road, and you will get through them as we've gotten through the others. And I appreciate the partnership.
Thank you. Thank you, Melinda. Yeah, no, really grateful, because we know that there is need in the community, but we also need to know how to do this right. And I did not realize how many hoops there were to jump through, so appreciate all of you, Brian, Cassie, Dr. Brooks, Amy, Laura, for, kind of seeing this process through, because there's there's a lot of different licensors, and there's also just the bricks and mortar piece of, making sure that there's that privacy element and that young people are being protected, both physically, and obviously with their mental health and needs. So, this is great work. I think the community is going to be really excited to see this happen. I know we are, and really remarkable that we were able to contemplate doing it in the current facility, because, the another facility, may happen, and it was certainly contemplated in the beginning, and really moving that forward before, as a trial kind of process I think is really important, that we're starting sooner than later on this work. So thank you very much. With that, it is 11:59, and so we'll say goodbye, and we're adjourned, and thank you all.